Okay, so I was asked to talk about managing survivorship and overcoming ovarian cancer. And just, I'm not going to spend a lot of time on this, but we do know of all the gynecologic cancers, ovarian cancer still remains the scariest. It's the most deadly of the gynecological malignancies. And even though our upfront treatments, which still unfortunately require chemotherapy, are effective, many people do relapse and ultimately succumb to the disease. As already stated by my colleagues, we are making such tremendous progress understanding the biology of ovarian cancer that we are seeing some tangible benefits that hopefully will continue to improve on these outcomes. I was asked to talk about survivorship, and I think one of the bigger questions, particularly for our constituents who are living with ovarian cancer, is actually exactly what is this survivorship? What does that exactly mean? When the Institute of Medicine, now called the National Academy of Science, Engineering, and Medicine, came out with their seminal report on survivorship, they really was taking it where people were lost in transitions, the transition being the end of chemotherapy with curative intent as they went on for the rest of their lives. And they did that for a reason, because people after getting treated for cancer were falling through the cracks. They were not getting screened for secondary malignancies. They were not getting flu shots at the same frequency that they should have. So there was a reason for it. But unfortunately, I think the response from the community was to ignore or not really acknowledge that people are survivors from the point of their diagnosis. And that's really the definition that was taken by the National Coalition of Cancer Survivors. And not only does it embrace survivorship from the point your life is turned around because of the diagnosis of cancer, it also includes your family, your friends, your loved ones, and sometimes even your community in this all-encompassing diagnosis of survivorship. And that's for a very good reason, which I'll touch to. So when we go about this presentation, recognize that the way I frame this, it starts at diagnosis, it goes through your chemotherapy, it goes through cancer-free survival and hopefully for cure, but it embraces the time after a recurrence or a relapse and goes towards the end of your life. So survivorship care is very much supportive care plus palliative care plus end-of-life care. It's all the same bucket. These are the 4 essential components of survivorship care that we'd like to think about, and I will propose to this group. These are relevant no matter where you are in your own cancer experience. We still are interested in trying to detect cancer, even if it's a recurrence, as early as possible. We want to undergo a surveillance that makes sense. We also want to intervene in the side effects of treatment as they occur and as they persist. We want to prevent you from getting another cancer or, as much as we can, recurrence or a late relapse. And then we want to make sure that the care is coordinated so we know who is catching that potential hot potato regarding mammography, who's going to be counseling someone about their heart risks. These are all important. This is what the Society of Gynecologic Oncology recommends in terms of creating what's called a treatment plan, a patient care plan. Time from completion of primary therapy typically is, goes in buckets. Acute survivorship within the first 2 years, all the way up to chronic or long-standing survivorship over 5 years. The bringing you back, seeing you, talking to you, examining you is frequent during the first 3 years, because that's when the vast majority of recurrences from epithelial ovarian cancer will happen. But it's important for non-epithelial ovarian cancer, those people living with that, the recurrences can be later. So perhaps your doctor will individualize that plan and say, I should just see you every 3 to 6 months as we go forward. And I'm not sure if I'll ever go to every year. Pap tests and cytologies are not indicated for people who are living with, surviving from ovarian cancer. And if you note here, the CA-125 is deemed optional, and I'll explain that in a minute. We do not recommend routine radiological imaging, but we will if you suspect a recurrence, if I suspect a recurrence, if our blood work suggests we need to look further. So what's this reason that it's optional to test a CA-125? We all recognize that when we're treating people for ovarian cancer in whom there's a blood test marker, we check it like hawks. We check it every 3 weeks. We check it monthly. We want to see it fall during chemotherapy. Why? It's a surrogate marker for how well the treatment is working. But after it's done, there is really no advantage to testing. But we recognize just saying you don't need it is not fair, because for lack of a better word, anyone who has had a CA-125 check during treatment develops an addiction to that. We want to know what those levels are. And it's not only you, your providers, your clinicians that have gotten to know you also want to know what that is. The reason that it's not been shown, or that we don't think it improves survival outcomes, is because we showed just that in a clinical trial out of Europe, where people were either blinded to their CA-125 results or they were given those results. And the bottom line from that big trial was that if you knew your CA-125 was going up, you started treatment earlier than if the disease presented either symptomatically or on exam. So earlier intervention, but it did not improve overall survival. The only thing that went down with earlier intervention was quality of life. So what do we know about these care plans? It's something I tend to think about more in people treated for breast cancer, but shouldn't we do survivorship care plans for people diagnosed with ovarian cancer? We did a social media study on Twitter with Teresa Hagan, who's now at Pittsburgh, and she asked the question directly: what are the survivorship needs for women treated for ovarian cancer? It was done as a tweet chat with the community on Twitter that goes by hashtag GYNCSM, of which Dr. Weston and I have been moderators. And the recruitment was in collaboration with multiple organizations and advocacy groups. These were the 5 questions that we focused in on during this talk, and these were disseminated to our partners as well. And during that conversation, which was 1 hour, there were over 370 unique tweets and over 43 people who participated. And each person who participated tweeted an average of 8 to 9 tweets. In the following 24 hours, in the following day after this tweet chat, even more people were commenting in this conversation. And this is what we're coming out as important words. This is a word bubble. The larger the bubble, the more common it came up: cancer, survivor, Chad, ovary. But if you look at the way periphery, these smaller bubbles that were coming up: worried, medical, special, communication, experience, advocacy, stories, lacking. When we ask people, to comment on survivorship, and we then looked at the results, we assigned them sentiment. Were these negative connotations, or they were associated with more positive connotations? And here you're seeing the word frequency, as well as whether it's skewed towards the negative or skewed towards the positive. The way I interpret this slide is that most people who participated in this tweet chat were overall more positive about their survivorship than they were negative. The words that were used were more frequent and frequently more positive than the ones that were not. But what did we learn in terms of thematically? There's a lack of support as people transition between end of treatment to the beginning of a recurrence, to the start of therapy, to a second remission, to a third recurrence. There was a lack of support as people went through their own journeys, and that the physical as well as the emotional needs were not being met by us. That did not mean that people with ovarian cancer were suffering. It meant they were doing it, finding their own path, navigating this process independently, but that they wanted us to be more proactive. They wanted us to be the ones to point them towards the resources. They wanted us to build care plans that were specific to their own risks of recurrence. And they wanted us to develop these plans that were inclusive of What happens if I do recur? So all of this goes out towards the important point of finding one's new normal. And the new normal is a concept, and it includes multiple themes. I'm going to highlight 4 here, but this is not it's not something that happens overnight. When I counsel women and men who have completed therapy, I typically say it may take up to a year before you find yourself in a new place that is comfortable, because these issues do come up. In terms of fear of recurrence, it is a real phenomenon. When we stop your treatments, when we take away the chemotherapy, when we stop the maintenance PARP inhibitors, it's as if we're taking away your tools towards healthiness. And all of a sudden, people are left on their own. It is a highly anxiety provoking situation. It can rise to the level of post traumatic stress syndrome, and it can affect other people. The risk factors: being younger when going through this, having children, but also having limited support, and then being diagnosed at a higher stage. Recognize that the people who are supporting you for these treatments, supporting you in this process, have that fear of recurrence too. They can be impacted, and they can be impacted even more than the person who just went through the cancer experience. It's important for us to understand if it's present, because there's very nice data that we can intervene. This is something called Conquer Fear. It was a psychological counseling program that was compared to relaxation survivors in over 200 people with cancer who had high fear of recurrence scores. Compared to relaxation, psychological counseling did lower fear of recurrence, and it lasted over the last 6 months. Going into sexual health, realize that it is not just about intercourse, that this is a construct that has multiple domains for women, including intimacy and sensuality, body image and arousal, desire, climax, as well as satisfaction. When I talk about this with patients, I take them through this model from Rosemary Basson, where women start off and wake up sexually because they want intimacy in their lives. They want something more. That wakes up their body such that when things are touched, it's stimulating, which leads to arousal. And that arousal feeds desire. And when desire is satisfied, this circle propagates. Every single one of these these arrows can be impacted by cancer surgery, cancer therapy, but they can also be rebuilt. The important point here for all of you listening, the link between desire and satisfaction does not require any singular sexual activity, okay? So you can enjoy a sexual activity, but it is very different, and it's a separate experience from satisfaction. This is why I tell people that when they look at their partner who's being nice and doing the dishes or doing the laundry, they feel so fulfilled and satisfied, and their intimacy is better, and they didn't go to bed. This explains that phenomenon, and it's real. There is also treatment, which is why we need to discuss sexual health. We can address vaginal health using vulvar vaginal moisturizers, or even hormonal therapy, which is safe after ovarian cancer. And we can also address sexual health, how to make things even more pleasurable. Hormone replacement is safe after ovarian cancer, and it can be done to manage menopausal symptoms, and has the added advantage of, yes, improving sexual function. Then we also talk about healthy lifestyles. Remember that a healthy lifestyle really depends on 2 things: the food you take in and the energy that is expended. And the guidelines are this: remember, even with ovarian cancer, heart disease is the #1 killer in women. In the Nurses' Health Study, walking at least 9 hours per week reduced bad cardiovascular outcomes by at least 50%. So that's a figure that we can take forward following the cancer diagnosis. These are the recommendations from the American Cancer Society and American College of Sports Medicine: maintaining a healthy weight, being active, eating healthy with limits on red meat and processed foods, and then limits on alcohol intake to 1 to 2 drinks per day. What is not on here? You do not need to avoid sugar. Cake is okay. Everything is okay in moderation. Then we talk about opportunities in financial health. We know out-of-pocket expenses can be very significant for anyone living with and dealing with cancer. In one study by Peroni, we saw that financial burdens at diagnosis lowered quality of life, but financial toxicity during treatment was associated with a mortality risk. This is something that is more and more upfront in how we help you survive cancer. Protecting and reacting to cancer costs has to be a proactive measure. Learning about how your insurance is written, what you're covered for, proactively reaching out to financial services, taking stock of what needs to be paid for and what is nice to have. If you are employed, learning about your options so you can keep your job, reaching out to social work, keeping a record of all your expenses, and asking your doctors to choose wisely. Do you need that CAT scan? What are you going to do with these results? These are well within your rights to ask us, and we should be able to tell you. It's all about meeting patients where they are. If you are newly diagnosed, your goal is rightfully for a cure. At the end of that treatment, the provision is to give you a care plan. But our job is not done, and you are still a survivor if you have relapsed or developed metastatic disease. The goal might not be cure. It might be control of that cancer so you can live as long as possible. Our provision is going to be symptomatic management, but that management can also include healthy lifestyles. As one becomes increasingly ill, the goal will be palliation. The hope should be for care so that you do not suffer. And then at the end of life, we are talking comfort care and the provision of hospice. Above all else, just remember from this talk, there is always room for hope. There's going to be hope in the research that's being done by my colleagues across the country and on this call. And there is hope provided by your treatment teams and your families, and that hope will sustain you. So in conclusion, just remember, you are not your cancer. Cancer should not be used to describe you. Change is inevitable after you get diagnosed, but so is recovery. And people with ovarian cancer face a different future from those with other, quote, more curative cancers like breast cancer. Therefore, our care plans should reflect that reality. And finally, never give up on hope. Thank you very much.